Hello and welcome to the CAPE training program. My name is John Leatherman. CAPE is short for Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. This training and related activities was sponsored by the Substance Abuse and Mental Health Services Administration, the U.S. Department of Agriculture, and the USDA network of regional rural development centers. The objectives of the program are to enhance behavioral health literacy by offering the mental health first aid workshop with an emphasis on substance abuse. Our second objective is to motivate the creation of community coalitions to address local behavioral health needs, such as those related to the opioid epidemic. Finally, we are encouraging the notion of formal action planning to create a community roadmap for improving the local situation. In this video, I'll continue discussing community needs assessment by talking about conducting primary research in the community using alternatives to surveys. Frequently, we pull people together for a presentation and discussion of some issue. People think it's important or they wouldn't have come. You have interested community leaders and community members together. You can simply ask them what they think. It's a variation of the key informant information gathering method we discussed earlier. This is a sampling of leaders and people who have interest and may have access to specialized information. If you think the right people are in attendance, you can simply ask them what they think. I always use this as part of the Community Health Needs Assessment program I offered in Kansas. After presenting data related to the local situation, I would ask the meeting participants questions like these. What do you think are the greatest needs and best solutions? What has to happen to get there? What role should such and such an entity play? In the case of the Community Health Needs Assessment, this was the hospital or the county health department. I had them write down their answers on a sheet of paper. They could provide as many answers as they cared to. I'd take them with me and record every one and begin the process of grouping them into themes. This was the start of trying to achieve a community consensus about needs and action priorities. Conducting representative community surveys can be costly. Another alternative that I have also used in the Health Needs Assessment program is what I call the Poor Persons Survey. Construct the survey you'd like people to complete. You hold your community meeting about an issue. Say 40 people attend. You have those 40 people complete the survey and give each person 5 blank surveys to take with them from the meeting. Instruct them to get 5 other people from the community to complete the survey. Tell them it can be anyone, co-workers, church members, other adult family members. Tell them they have 3 or 4 days to get the completed survey to a designated drop-off point for shipment to you. If you have 40 surveys from the meeting and each collects 5 more, that's 240 completed responses. It's not representative, but it is a lot of input. I once did this in a county of 4,000 population. In 3 days, they shipped 452 completed surveys. A few words about potential local data sources. There are many local institutions that gather unique and detailed information. Some examples might be police patrol encounters involving people with apparent mental health problems, jail inmates with mental health or substance abuse problems, counts by type of psychiatric diagnosis in the hospital emergency room, counts by type of short-term intervention at the local crisis center, homeless census interviews. Local data of this type can shed light on the scale of a problem or help identify emerging problems such as drug overdose and arrests. The challenge is to get cooperation. Some of the challenges include potential additional time, effort, and cost of collecting and tracking data. There may be privacy concerns, although simple counts wouldn't usually reveal anyone's identity. There is also a certain administrative prerogative. You may gain the trust and cooperation of one agency administrator. That person is replaced and the next administrator says, no, we can't do that. One example of gathering unique local data came earlier in the CAPE project. That was the idea of creating a community behavioral health surveillance system. In a dozen communities from around the country, panels of observers were recruited. These people had contact with distressed populations. These included mental health counselors, caseworkers, law enforcement, hospital workers, and others. We sent them internet-based surveys at regular intervals over the course of a year. We simply asked what behavioral health problems they were seeing and whether they thought it was getting better or worse. To wrap up our discussion of local data gathering, I'd like to say a few words about building strong evidence-based arguments. Frequently, a problem exists in the community and we want to do something or see something done about it. That typically requires marshaling financial resources or convincing others to make it a priority. At the CAPE website, you'll find a number of resources, including this webinar by Mark Skidmore, Measuring and Building Public Value of Health Intervention Programs. He considered the challenge of trying to build support for the idea of adopting a substance abuse intervention initiative. He hunted the research literature to find financial information about both the costs and benefits of substance abuse. The benefits of intervention included enhancing the income earning potential of the person treated. Treatment also enhanced the quality of life for the person and his or her family. Society in general avoided the costs associated with lost productivity and punitive intervention. Productive activity by the person seeking treatment generated more tax revenue. It also freed revenue for other needs. The costs included the resources needed to start and operate the intervention. He compared the benefits and the costs and concluded the intervention both paid for itself and generated a surplus. Mark acknowledged that his cost-benefit analysis was far from definitive or perfect. His conclusion was that a thoughtful, though imperfect evaluation was far better than no evaluation at all. My takeaway from his presentation was that you have to be prepared to make your case with more than saying there is a need and the intervention is the right thing to do. In my experience working in many rural communities, there are many social service needs, but the roads and bridges always win. As much as possible, we need to come prepared with evidence. Document the need. Show evidence of intervention success. Demonstrate as much as possible the cost effectiveness of undertaking the intervention. At least as far as working with local government officials and many business leaders, stories are good, but they tend to focus on the finances. That concludes my discussion of community needs assessment. From here, we'll have a couple of videos talking about assessing community preparedness. That will include identifying community stakeholders, assets, and history. We'll also talk about building community coalitions and preparing community public relations. Here's how to get in touch with us. Thank you for watching.